The Standard Edition of the Complete Psychological Works of Sigmund Freud, Volume 1. Observation of a Severe Case of Hemi-Anaesthesia in a Hysterical Male, 1886. Editor's Note. This paper seems never to have been reprinted. The present translation by James Strachey is the first into English. It was apparently intended that this should be the first of a series of papers, since there is a superscription which reads, Beitrag zur Casuistik der Hysterie 1, Contributions to the Clinical Study of Hysteria 1, but the series was not continued. On October 15, 1886, some 6 months after his return from Paris, Freud read a paper before the Vienna Gesellschaft der Ärzte, Society of Medicine, with the title Über männliche Hysterie, on male hysteria. The text of this paper has not survived, though reports of it appeared in the Vienna medical periodicals, for instance, in the Wien Medwönscher, Volume 36, number 43, pages 1444-6, October 23rd. It is also shortly summarized by Ernest Jones, 1953, page 252. Freud himself gives an account of the occasion in his autobiographical study, 1925D, Standard Edition, Volume 20, page 15. The paper was badly received, and Meinert challenged Freud to present a case of male hysteria before the society. He met with some difficulty in finding one, since the senior physicians of the departments in the General Hospital refused to allow him to use their material. Eventually, with the help of a young laryngologist, he found a suitable patient elsewhere, and presented him before the Gesellschaft der Ärzte on November 26, 1886. The case was demonstrated by Freud and by his friend Dr. Konigstein, the ophthalmic surgeon, who had made an examination of the patient's eye symptoms. The latter's paper was printed in the Wochenschrift a week later than Freud's, in the issue of December 11th, 16 pages or numbers 1674 through 6. Freud tells us that the present paper met with a better reception than its predecessor, but nevertheless failed to arouse interest. The greater part of the paper, it will be seen, is concerned with the physical phenomena of hysteria, on the lines characteristic of Charcot's attitude to the condition. There are only some very slight indications of an interest in psychological factors. Observation of a severe case of hemi-anesthesia in a hysterical male. Gentlemen, when on October 15th I had the honor of claiming your attention to a short report on Charcot's recent work in the field of male hysteria, I was challenged by my respected teacher, Hofrat Professor Meinert, to present before the Society some cases in which the somatic indications of hysteria, the hysterical stigmata by which Charcot characterizes this neurosis, could be observed in a clearly marked form. I am meeting this challenge today, insufficiently, it is true, but so far as the clinical material at my disposal permits, by presenting before you a hysterical man who exhibits the symptom of hemi-anesthesia to what may almost be described as the highest degree. Before beginning my demonstration, I will merely remark that I am far from thinking that what I am showing you is a rare or peculiar case. On the contrary, I regard it as a very ordinary case of frequent occurrence, though one which may often be overlooked. For this patient, I have to thank the kindness of Dr. von Berigzasi, who sent him to me for confirmation of his diagnosis. The patient is a 29-year-old engraver, August P., now before you, an intelligent man who readily offered himself for my examination in the hope of an early recovery. Allow me to begin with an account of his family history and of his life story. The patient's father died at the age of 48 of Bright's disease. He was a cellar man, a heavy drinker, and a man of violent temper. His mother died at the age of 46 of tuberculosis. She is said to have suffered much from headaches in earlier years. The patient has nothing to say of attacks of convulsions or anything of the sort. This couple were the parents of 6 sons, of whom the first led an irregular life and succumbed to a syphilitic cerebral affection. The second son is of special interest for us. He plays a part in the etiology of his brother's illness and seems to have been a hysteric himself, for he told our patient that he had suffered from attacks of convulsions, and by a strange coincidence, this very day I met a Berlin colleague who treated his brother in Berlin during an illness and had diagnosed him as suffering from hysteria, a diagnosis which was also confirmed in a hospital there. The third son is a deserter from the army and has since disappeared. The fourth and fifth died at an early age, and the last is our patient himself. Our patient developed normally in his childhood. He never suffered from infantile convulsions and went through the usual children's diseases. In his 8th year, he had the misfortune of being run over in the street. He sustained a rupture of the right eardrum, with permanent impairment of hearing in the right ear, and he fell sick of an illness which lasted for several months, during which he suffered frequently from fits, the nature of which it is no longer possible to discover today. These fits continued for some 2 years. To this accident dates back a slight intellectual dullness which the patient claims to have noticed in his progress at school, and a tendency to feelings of giddiness whenever he was unwell for any reason. Later he completed his schooling, and after his parents' death was apprenticed to an engraver, and it speaks very favorably for his character that he remained as journeyman with the same master for 10 years. He pictures himself as a person whose thoughts were wholly and solely directed to perfection in his skilled craft, who with that end in view did much reading and drawing, and denied himself all social intercourse and all entertainments. He was obliged to reflect a great deal about himself and his ambition, and in doing so often fell into a state of an excited flight of ideas, in which he became alarmed about his mental health. His sleep was often disturbed. His digestion was slowed down by his sedentary way of life. He has suffered from palpitations for the last 9 years, but otherwise he was healthy and never interrupted in his work. His present illness dates back for some 3 years. At that time, he fell into a dispute with his dissolute brother, who refused to pay him back a sum of money he had lent him. His brother threatened to stab him and ran at him with a knife. This threw the patient into indescribable fear. He felt a ringing in his head, as though it was going to burst. He hurried home without being able to tell how he got there, and fell to the ground unconscious in front of his door. It was reported afterwards that for 2 hours he had the most violent spasms, and had spoken during them of the scene with his brother. When he woke up, he felt very feeble. During the next 6 weeks, he suffered from violent left-sided headaches and intracranial pressure. The feeling in the left half of his body seemed to him altered, and his eyes got easily tired at his work, which he soon took up again. With a few oscillations, his condition remained like this for 3 years, until, 7 weeks ago, a fresh agitation brought on a change for the worse. The patient was accused by a woman of a theft, had violent palpitations, was so depressed for about a fortnight that he thought of suicide, and at the same time a fairly severe tremor set in his left extremities. The left half of his body felt as though it had been affected by a slight stroke. His eyes became very weak, and often made him see everything gray. His sleep was interrupted by terrifying apparitions, and by dreams in which he thought he was falling from a great height. Pains started in the left side of his throat, in his left groin, in the sacral region, and in other areas. His stomach was often, quote, as though it was blown out, end quote, and he found himself obliged to stop working. A further worsening of all these symptoms dates from the last week. In addition, the patient is subject to violent pains in his left knee and his left sole if he walks for some time. He has a peculiar feeling in his throat, as though his tongue was fastened up. He has frequent singing in his ears, and more of the same sort. His memory is impaired for his experiences during his illness, but is good for earlier events. The attacks of convulsions have been repeated from 6 to 9 times during the 3 years, but most of them were very slight. Only one attack at night last August was accompanied by fairly severe shaking. And now to consider the patient, a rather pale man of mediumly powerful development. The examination of his internal organs reveals nothing pathological apart from dull cardiac sounds. If I press on the point of exit of the supraorbital, infraorbital, or mental nerves on the left side, the patient turns his head with an expression of severe pain. There is, therefore, we might suppose, a neuralgic change in the left trigeminal. The cranial vault, too, is very susceptible to percussion in its left half. The skin of the left half of the head behaves, however, quite differently to our expectation. It is completely insensitive to stimuli of any kind. I can prick it, pinch it, twist the lobe of the ear between my fingers, without the patient even noticing the touch. Here, then, there is a very high degree of anesthesia, but this affects not merely the skin, but also the mucous membranes, as I will show you in the case of the patient's lips and tongue. If I insert a small roll of paper into his left external auditory meatus, and then through his left nostril, no reaction is produced. I now repeat the experiment on the right side, and show that there the patient's sensibility is normal. In accordance with the anesthesia, the sensory reflexes, too, are abolished or reduced. Thus I can introduce my finger and touch all the pharyngeal tissues on the left side without the result being retching. The pharyngeal reflexes on the right side are, however, also reduced. Only when I reach the epiglottis on the right side is there a reaction. Touching the left conjunctiva, palpebrarum, and bulbi produces scarcely any closure of the lids. On the other hand, the corneal reflex is present, though very considerably reduced. Incidentally, the conjunctival and corneal reflexes on the right side are also reduced, though only to a lesser degree, and this behavior of the reflexes is enough to enable me to conclude that the disturbances of vision need not be limited to the one left eye. And in fact, when I examined the patient for the first time, he exhibited in both eyes the peculiar polyopia monocularis of hysterical patients, and disturbances of the color sense. With his right eye, he recognized all the colors except violet, which he named as gray. With his left eye, he recognized only a light red and yellow, while he regarded all the other colors as gray if they were light and black if they were dark. Dr. Koenigstein was kind enough to submit the patient's eyes to a thorough examination, and will himself report later on his findings. See page 24 above. Turning to the other sense organs, smell and taste are entirely lost on the left side. Only hearing has been spared by the cerebral hemi-anesthesia. It will be recalled that the efficiency of his right ear has been seriously impaired since an accident to the patient at the age of 8. His left ear is the better one. The reduction in hearing present in it is, according to a kind communication from Professor Gruber, sufficiently explained by a visible material affection of the tympanic membrane. If we now proceed to an examination of the trunk and extremities, here again we find an absolute anesthesia, in the first place in the left arm. As you see, I can push a pointed needle through a fold of the skin without the patient reacting against it. The deep parts, muscles, ligaments, joints, must also be insensitive to an equally high degree, since I can twist the wrist joint and stretch the ligaments without provoking any feeling in the patient. It tallies with this anesthesia of the deep parts that the patient, if his eyes are bandaged, also has no notion of the position of his left arm in space, or of any movement that I perform with it. I bandage his eyes and then ask him what I have done with his left hand. He cannot tell. I tell him to take hold of his left thumb, elbow, shoulder with his right hand. He feels about in the air, will perhaps take my hand, which I offer him, for his own, and then admits that he does not know whose hand he has hold of. It must be especially interesting to find out whether the patient is able to find the parts of the left half of his face. One would suppose that this would offer him no difficulties, since, after all, the left half of his face is, so to speak, firmly cemented to the intact right half. But experiment shows the contrary. The patient misses his aim at his left eye, the lobe of his left ear, and so on. Indeed, he seems to find his way about worse in groping with his right hand for the anesthetic parts of his face than if he were touching a part of someone else's body. The blame for this is not a disorder in his right hand, which he is using for feeling about, for you can see with what certainty and speed he finds the spot when I tell him to touch places in the right half of his face. The same anesthesia is present in his trunk and left leg. We observe there that the loss of sensation has its limit at the midline or extends a trace beyond it. Special interest seems to me to lie in the analysis of the disturbances of movement which the patient exhibits in his anesthetic limbs. I believe that these disturbances of movement are to be ascribed wholly and solely to the anesthesia. There is certainly no paralysis of his left arm, for instance. A paralyzed arm either falls limply down or is held rigid by contractures in forced positions. Here it is otherwise. If I bandage the patient's eyes, his left arm remains in the position it had taken up before. The disturbances of mobility are changeable and depend on several conditions. At first, those of you who noticed how the patient undressed himself with both hands and how he closed his left nostril with the fingers of his left hand will not have formed an impression of any serious disturbance of movement. On closer observation, it will be found that the left arm, and in particular the fingers, are moved more slowly and with less skill, as though they are stiff, and with a slight tremor. But every movement, even the most complicated, is performed, and this is always so if the patient's attention is diverted from the organs of movement and directed solely to the aim of the movement. Footnote 1. Confer in this connection a footnote to Appendix C to the project, page 394 below. On closer observation, it will be found that the left arm, and in particular the fingers, are moved more slowly and with less skill, as though they are stiff, and with a slight tremor. But every movement, even the most complicated, is performed, and this is always so if the patient's attention is diverted from the organs of movement and directed solely to the aim of the movement. It is quite otherwise if I tell him to carry out separate movements with his left arm, without any remoter aim. For instance, to bend his arm at the elbow joint, while he follows the movement with his eyes. In that case, his left arm appears much more inhibited than before. The movement is performed very slowly, incompletely, in separate stages, as though there were a great resistance to be overcome, and is accompanied by a lively tremor. The movements of the fingers are extraordinarily weak in these circumstances. A third kind of disturbance of movement, and the severest, is exhibited finally if he is expected to carry out separate movements with closed eyes. Something results, to be sure, with the limb, which is absolutely anesthetic, for, as you see, the motor innervation is independent of any sensory information, such as normally flows in from a limb that is to be moved. This movement, however, is minimal, not in any way directed to a particular segment, and not determinable in its direction by the patient. Do not assume, however, that this last kind of disturbance of movement is a necessary consequence of anesthesia. Precisely in this respect, far-reaching individual differences are to be found. We have observed anesthetic patients at the Salpêtrière who, if their eyes were closed, retained a much more far-reaching control over a limb that was lost to consciousness. Footnote 1. Confer Charcot, 1886. The reference is to a case reported in Lecture 22 of the volume of Charcot's lectures, which Freud had just translated. See in particular page 295 of the German version. Freud, 1886, F. The same influence of diverted attention and of looking applies to the left leg. For a good hour today, the patient walked along the streets with me at a rapid pace, without looking at his feet as he walked, and all I could notice was that he put his left foot down, turning it rather outwards, and that he often dragged it along the ground. Footnote 2. This characteristic is the subject of a footnote in Freud's French paper on organic and hysterical paralysis, 1893c, page 163 below. But if I order him to walk, then he has to follow every movement of his anesthetic leg with his eyes, and the movement occurs slowly and uncertainly, and tires him very soon. Finally, with his eyes closed, he walks altogether uncertainly, and he pushes himself along with both feet staying on the ground, as one of us would do in the dark on unknown territory. He also has great difficulty in remaining upright on his left leg only. If he shuts his eye in that position, he immediately falls down. I will go on to describe the behavior of his reflexes. They are in general brisker than the normal, and moreover show little consistency with one another. The triceps and flexor reflexes are decidedly brisker in the right non-anesthetic extremity. The patellar reflex seems brisker on the left. The Achilles tendon reflex is equal on both sides. It is also possible to elicit a slight patellar response, which is more clearly observable on the right. The cremasteric reflexes are absent. On the other hand, the abdominal reflexes are brisk, and the left one immensely increased, so that the lightest stroking of an area of the abdominal skin provokes a maximal contraction of the left rectus abdominis. In accordance with a hysterical hemi-anesthesia, our patient exhibits, both spontaneously and on pressure, painful areas on what is otherwise the insensitive side of his body, what are known as hysterogenic zones. Footnote 3. See the account of these in the article on Hysteria, 1888b, page 43 below. In accordance with a hysterical hemi-anesthesia, our patient exhibits, both spontaneously and on pressure, painful areas on what is otherwise the insensitive side of his body, what are known as hysterogenic zones, though in this case their connection with the provoking of attacks is not marked. Thus, the trigeminal nerve, whose terminal branches, as I showed you earlier, are sensitive to pressure, is the seat of a hysterogenic zone of this kind. Also a narrow area in the left medial cervical fossa, a broader strip in the left wall of the thorax, where the skin too is still sensitive, the lumbar portion of the spine, and the middle portion of the os sacrum. The skin is sensitive over the former of these as well. Finally, the left spermatic cord is very sensitive to pain, and this zone is continued along the course of the spermatic cord into the abdominal cavity to the area which in women is so often the site of overalgia. I must add 2 remarks relating to deviations of our case from the typical picture of hysterical hemi-anesthesia. The first is that the right side of the patient's body is also not free from anesthesia, though this is not of a high degree, and seems to affect only the skin. Thus there is a zone of reduced sensitivity to pain and feeling of temperature over the dome of the right shoulder, Another passes in a band round the peripheral end of the lower arm. The right leg is hypoesthetic on the outer side of the thigh and on the back of the calf. A second remark relates to the fact that the hemi-anesthesia in our patient exhibits very clearly the characteristic of instability. Thus, in a test for electrical sensitivity, contrary to my intention, I made a piece of skin at the left elbow sensitive, and repeated tests showed that the extent of the painful zones on the trunk and the disturbances of the sense of vision oscillated in their intensity. It is on this instability of the disturbance of sensitivity that I found my hope of being able to restore the patient in a short time to normal sensitivity.